Hi, everyone. Thank you so much for joining in so promptly to our final ECHO session on the topic of chronic kidney disease. My name's Adelaide Boylan, and I'm a GP from Norwood. And as we sort of slowly welcome people in, I thought we'd start with an acknowledgement of country. So I'd like to acknowledge the Aboriginal and Torres Strait Islander people as the traditional owners of this country. We pay tribute to their physical and spiritual connection to the land, waters and community, enduring now as it has been throughout time. And we pay respect to Aboriginal and Torres Strait Islander people, to their culture and to elders past, present and emerging, and particularly welcome any Aboriginal or Torres Strait Islander people joining our meeting this evening. So as I said, my name's Adelaide. I'm really delighted to welcome you all to our last session as we get very close in the run up to Christmas. We're delighted this evening to welcome Professor Randall Fall, who's a consultant nephrologist at Carlin and also a Professor of Medicine at the University of Adelaide, and also Raymond Trong, who is a clinical pharmacist. Raymond, you use a different term though, sorry, not clinical, consultant.
Consultant pharmacist, and I specialize in medication management reviews, so your home medication reviews and residential medication management reviews in the community, as well as an aged care on-site pharmacist.
Super. So thank you for joining us again, Raymond. We would love for people to have your cameras on if you're in a situation where you're able to do that, so that we can be a little bit interactive. And we'd really be delighted if people would introduce themselves via the chat box. So we're keen to know who you are, where you are, and what you do. If you're an allied health professional, if you're a GP, if you're something else, please let us know. It's always interesting to know who's participating in the meetings. And in a moment, what we'll do is I'll hand over to Professor Fall to further introduce himself if he would like to, and to start his presentation. But just wanted to remind people, because we do have some new faces tonight, to please not ask questions during the presentation. So we record the didactic presentation, and that will be popped on the SAPMEA website for you to review later if you wanted to. But afterwards, we've got heaps of time for questions, so pop them in the chat box or put up your virtual hand and I'll come to you afterwards, and we'll definitely get through everyone's questions. We've got a bit of a case discussion later as well, and we'd really welcome comments, questions, thoughts in that part of the presentation too. There aren't any specific announcements from SAPMEA in relation to this ECHO, but keen for people to know, and we'll reiterate this at the end, that next year, starting from February, there's a frailty ECHO, and you can sign up for that on the SAPMEA website now. And also that the CPD points for this ECHO series, so the 5 sessions we've done, will be popped onto your college platform at the end of next week. So no need to contact SAPMEA to chase up your points before the end of next week. They'll definitely get done. All right, all that said, welcome people who've subsequently joined. I'm Adelaide, I'm a GP from Norwood. I'm going to hand over to Professor Fall to talk to us about the GP management of CKD and guidelines for specialist referral. Thanks so much, Randall.
Thanks, Adelaide. What I'm going to do, my talk is really more or less a series of sort of tips about certain points. And some of the things I'll say are perhaps going to be a little different to some of the things you've heard in other forums, but I'll happily explain why I've said these things. And at the end, very happy to answer questions about pretty much anything. So questions don't necessarily have to be about the content of my talk. If you wish to ask other questions about chronic kidney disease or kidney disease in general, and some management questions. So our next, please. Okay, so what I'm going to do is start what seems simple, but I think is not quite as simple as is often made out. And that's how you diagnose chronic kidney disease. And I really want to talk specifically about the role of estimated GFR, because I think personally, the estimated GFR often creates a fair bit of confusion for people. So it's a fact that your renal function and hence your glomerular filtration rate, or GFR, steadily declines with age. And this is a normal part of the aging process. But despite this, your serum creatinine will stay in the normal range throughout your life, unless there is a non-age related problem in your kidneys. And the reason for that your creatinine staying the same essentially, but your GFR declining, is that it's largely due to decreased muscle mass with age, and hence creatinine, which comes from creatine kinase, which comes from muscle. There's lower production of creatinine, and so you have a lower serum creatinine level than you might otherwise have. The other thing to remember is that your renal function, or GFR, is proportional to your body size. It's also important to remember that females have less renal function than males, approximately 85% on average, because they have smaller kidneys. And so the normal range for females is actually lower than the normal range for males. Okay, so that's an introduction to this bit of the topic. Next, thanks, Masala. Okay. So the estimated GFR, eGFR, is a calculated value, and it's not a direct measure of kidney function. It's based on your sex, your age, and your creatinine level, and does not take into account a person's size. Unlike the Cockcroft-Gault equation that some of you may be familiar with, which has been around for a long time, has a lot of problems with accuracy, but actually takes into account a person's weight. So it's at least trying to compensate for a person's size. So that's why the eGFR is normalized to 1.73 meter body surface area, which is the average body surface area of average person. So the assumption is that if your average if your surface area is that height, this is what your GFR will approximate to. There's a part of the calculation where it's automatically adjusted for females by 0.85, and because the calculation is inversely proportional to age, your eGFR will fall with age. And it's happening to all of us as we're sitting in this room. The categories of chronic kidney disease that you've become increasingly familiar with, 1 to 5, do not take into account age or your sex. So it's not that if you're 90 years old, this is what the eGFR should be for a 90-year-old. It's assuming that everyone's the same, and there's no taking into account the difference between males and females. So what that means is that females, because it's multiplied by 0.85, will disproportionately have more CKD, chronic kidney disease, based on the eGFR. But in fact, the incidence of end-stage kidney disease is significantly more in males. So there's already a contradiction in there about when you use an eGFR. And similarly, most individuals will actually develop, I put chronic kidney disease in inverted commas, if they live long enough, even if they have no other evidence of renal disease. So I'm sure many of you look after people who are really quite elderly. So if you looked at the eGFR of all your 90-year-olds, I guarantee they'd all meet a definition of chronic kidney disease because their eGFR would be low. But the primary reason their eGFR is low is because they're 90, not because they specifically have a kidney problem that's more than just age-related decline. Next. So I'm getting around to the practical implications for this. So diagnosing chronic kidney disease, and this is the Randall Fall view of the renal world, okay? That's what I mean. It'll be a bit different to what you may have been told by a lot of people. Diagnosing chronic kidney disease based simply on eGFR is quite problematic. Many elderly people, particularly females, are said to have chronic kidney disease, but they're actually simply old. Your eGFR will always decline with time. That is normal, and it's part of the calculation. It has to, because the calculation takes into account age. It's inversely proportional age. And so apart from occasional unusual circumstances, a creatinine level that's in the normal range means that that individual has appropriate kidney function for their age and sex. So even though their eGFR may seem low or may be calculated to be low, if their creatinine level is 90 or whatever, that means their kidney function is normal for their age and whether they're male or female. The other thing I always, and when I lecture students about the medical students, I really make a point of this one as well. You need, and it perhaps is not, it's applicable sometimes in general practice, because the eGFR isn't a direct measure of your actual GFR. You've got to be very careful in using it to calculate the dose of critical dose medications. And that includes things like aminoglycosides, which are much more used in the hospital system, low molecular weight heparin when the cutoff is that you halve the dose, etc. Because you're not actually measuring the person's actual GFR. And it's particularly important at extremes of body size. So you'll have a situation where someone who weighs 50 kilograms and someone who weighs 150 kilograms will have the same age, same sex, same creatinine level. So their eGFR will be exactly the same. But in fact, their actual GFR will be different by threefold because they're 3 times the size. So you need to just be careful about relying too much on the eGFR for calculating the dose of certain medications where the dosing is very important. Okay, next. Okay, so I'm going to now talk about what I consider to be actual chronic kidney disease. So the times to be concerned about actual chronic kidney disease are when the serum creatinine is elevated and when there are urinary abnormalities, particularly protein, plus or minus blood. Now, if you have hematuria alone, it's much more likely to be a urological problem. But if you have protein, that's clearly a sign, excess protein, that's clearly a sign of renal problems. And protein plus blood is also clearly renal problems. And so I always tell people that just good old-fashioned urinalysis is actually very powerful, very useful, and I do it all the time. And when people refer to me, that is one of the most useful things to do. You also need to take into account trends and changes. So if someone has elevated creatinine level but it's stable over a prolonged period, that's much less problematic than if has become abnormal or is increasing. And the similar thing applies to proteinuria. Low levels of proteinuria that are stable, much less to be concerned about, as opposed to new onset proteinuria or increasing proteinuria. Next, thanks, Sarah. Okay, so these are some sort of very general things I'm going to say. What can a general practitioner do about chronic kidney disease? Or what should a general practitioner do about chronic kidney disease? I think it is very reasonable and simple to do urinary protein levels. I like to have done a urine microscopy or urinalysis because whether there's blood in the urine also changes the way you think about the diagnosis, as opposed to what's often the case where people will do a microalbumin or an albumin level, but you won't know whether there's red blood cells as well because the diagnostic possibilities are significantly different. And it's very reasonable when we get referrals. It's always really nice if people have done some sort of imaging, and ultrasound is the most simple one and often the most useful. In terms of very general comments about treatment, assess and treat risk factors for chronic kidney disease, which are broadly very similar to those for cardiovascular disease. Treat blood pressure, treat lipids, treat diabetes, manage obesity. So these are all very much bread and butter for general practitioners. Next, please. Okay, so I'm going to make a few comments about medications. It's still first line for renal physicians, first line treatment of hypertension are either ACE inhibitors or A2 receptor blockers. There's particularly good evidence that they do have specific advantages in people with what I call proteinuric renal diseases, so renal disease where there's proteinuria, but also just as good, they're good treatment for hypertension, full stop. And so in diabetic nephropathy, which is one of the more common things we see, there's lots of very compelling evidence in the literature that these either ACE inhibitors or A2 receptor blockers have significant advantages over other antihypertensives. Having said that, the primary aim is still to get people's blood pressure under good control. And so many of our patients are on 2, 3, 4, or even occasionally 5 antihypertensives. But the starting point would generally be with an ACE inhibitor or an A2 receptor blocker. for myself or for nephrologists, the main limiting side effect for these medications, for the ACE inhibitors and A2 receptor blockers, is hyperkalemia. But that usually only becomes a problem with quite advanced chronic kidney disease. So that would be the most common reason that we would be stopping these agents when someone is generally getting pretty close to dialysis, where the potassium becomes a limiting problem. When you start someone, particularly someone who's already got reduced kidney function on an ACE inhibitor and A2 receptor blocker, they'll tend to get a bit of a rise initially, maybe 20%, but then it usually should settle back. There's still at times a bit of a fixed false belief out there that it's, if the renal function goes off when you start a ACE inhibitor and A2 receptor blocker, that it's dangerous and you should stop it. Some of that derives from the very, very occasional time where people have got bilateral severe renal artery stenosis, and you put them on an ACE inhibitor and A2 receptor blocker and their renal function goes off. I think I've seen that twice in my entire career. And what it means when it happens, their creatinine goes off from, say, 100 to 500. It's dramatic. It's not just a small rise. And so in general terms, stopping ACE inhibitors or A2 receptor blockers, if your creatinine level is slowly rising, is actually not the correct thing to do. In fact, there was a large study that was published in the New England Journal of Medicine a few years ago now, where they tested this, and they showed that patients where, and it was a randomized controlled trial where people had their ACE inhibitors stopped versus persisted with, the people where it was stopped actually did worse. So it's I know it's a very common maneuver that people get worried, creatinine's gone up, we better stop the ACE inhibitor. But what I'm saying is that that's only really needed in either if the creatinine's increased dramatically. So we do routinely do that in someone who's got acute kidney injury, but that's just a temporary thing because it helps recover from acute kidney injury. Next. So now the renal world has become more complicated in the last 5 or so years because there's a whole bunch of new agents that have come along, and they've all been supported by really strong, big clinical trials. There are ongoing uncertainties about these, and I'll mention them a little bit, and I think they were talked about at the last talk as well. What we don't really know yet is whether they have additive effects. I was at the big American meeting 3 or 4 weeks ago, and it's become quite popular in Europe to put people on multiple new things at once. But strictly speaking, the evidence to do that is not really there yet, and it does mean you've got to hypothesize that there'll be additive benefits when clearly there's additive risks as well. And it's also not that clear which particular patients are most likely to benefit. So one of the agents, finerenone, which I'll mention briefly, is really only in the PBS for diabetes. So that's because that's where the studies have been done. But I've got a lot of patients I've been following for years who've had sort of stable chronic kidney disease. And I think, well, what am I going to do them any benefit by putting them on additional agents apart from what they're already on? And I don't really have a clear answer for that because I don't know the answer. Anyway, the ones that are had most penetration are the SGLT2 inhibitors, particularly dapagliflozin, for example. Finerenone has had not a lot of penetration in Australia as yet. I think we'll gradually get there. And there's also, not surprisingly, there's studies about using GLP-1 agonists like semaglutide. That's been somewhat problematic in Australia because there's been this big shortage, which is over the last year or so. So next, please. So SGLT2 inhibitors being used a lot, quite clear, quite strict, but clear PBS criteria. You will get an initial decline in kidney function, but the idea is that it flattens the curve out. And what I mean by the deterioration will flatten out. That's the idea. And the studies do support that. And as I said, the question I constantly ask myself, would this patient benefit from me doing this if they've been stable for a long time? And I don't know the answer to that because you're talking about a benefit over maybe many years. Next. Finerenone is, as I said, has had pretty limited penetration. There's very little use in our department of this as yet. It's got very strict PBS criteria. And you already have to be on an ACE inhibitor, an A2 receptor blocker, and an SGLT2 inhibitor. Their renal function will predictably drop initially. The main thing to be concerned about is the potassium will go up, which is already a problem for renal physicians. And so you mustn't use it in combination with spironolactone. So at least for me, I'm still a bit unclear about how much of a role it's going to have, but it's a bit of a watch this space. Next. Okay. So change of direction slightly. What I'm going to say now is when I think this, and this is based on sort of referrals we get, when you don't need to refer to a nephrologist. So I've already talked about CKD that's not actually CKD. That's what I'm talking about, CKD based on eGFR alone, or a decline in eGFR in someone whose creatinine levels in the normal range. Microalbuminuria with normal renal function in the setting of known risk factors such as diabetes, hypertension, vascular disease. That's something that very much can and should be handled by general practice. I had a referral for one today, for example, again, and the management's very clear. It's treat their risk factors, put them on an ACE inhibitor and A2 receptor blocker, and that's what I will say, and then I'll send them back saying you're doing the right things. Almost invariably, that's already happening. So the referral is more about seeking some reassurance, and I really think that should stay in the hands of a general practitioner. Long-term, stable, mildly elevated creatinine level in an elderly person. How you define elderly depends on the individual, but someone, like an 85-year-old with a creatinine of 180 that's been stable for some time, they're not going to die of renal failure. And it's if you refer them to a nephrologist, very unlikely they will change anything from what you already do. Another one that comes up semi-regularly, people, where someone's had a nephrectomy and their creatinine will go up. So typically if you have a nephrectomy, you've got, let's say, 2 normal kidneys. The remaining single kidney will increase to about 65% or 2/3 of kidney function of 2 kidneys, which means your creatinine level would typically rise about 35%. And that's exactly what you expect. That's what we see with live kidney donors. That's what we tell people that is normal. So someone's creatinine going from 90 to 130 after a nephrectomy is what you expect. It's normal for that situation. And the only time we get worried about that is if they've got associated proteinuria, because that might suggest that the remaining kidney is not very healthy. So if someone has had a nephrectomy, kidney function stable, albeit higher than before, normal urinalysis, that's a situation where you can just observe. And then the last one is just about structural abnormalities. So it's just generally, if someone's got renal stones, they need to be a urological referral, not a renal referral. So if it comes to us, we'll say redirect to urology. Apart from people who've got lots and lots of cysts where it may be polycystic kidney disease. So a few cysts are actually very common in elderly people and of no consequence. But if someone has a family history of renal disease and they got dozens and dozens of cysts in their kidneys, they probably got polycystic kidney disease, and it's reasonable for them to be seen by a nephrologist and observed or watched. Next. When to refer to a nephrologist. So an elevated creatinine level in a young person is very significant. And that needs to be taken very seriously. Heavy proteinuria, yes, send them to us because we can sort through that, and they may need a kidney biopsy to work out what's going on. A combination of significant proteinuria and hematuria, that basically means they've got some form of glomerulonephritis. That's very much in the renal world, probably will need a renal biopsy. And in the situation of declining renal function, and I've made the point about in the setting of as measured by creatinine level going up, but just be aware of natural fluctuations. Your creatinine goes up and down like any of your chemistry, but if it's clearly a trend of decline, that's where good to send it to us. Next one. As opposed to when to urgently send it to a nephrologist. Now that's when, and we have our triage system at the Royal Adelaide. We're very responsive to situations of urgency, or what we define as urgency. So someone who's got rapidly deteriorating kidney function without a clear reversible cause. So someone, for example, if they're profoundly dehydrated, generally the first thing to do is to give them intravenous fluids or lots of fluids, and but if without a clear reversible cause, that's when we need to be involved. People with advanced renal impairment, particularly how you define advanced, but let's say 300 is we would be quite responsive to seeing them within a few weeks at the most. People with very heavy proteinuria or nephrotic syndrome with low serum albumin and edema, we can help with the management of the edema, but often the approach there will be doing a renal biopsy to establish the diagnosis and some sort of treatment regime. And as I said, hematuria and proteinuria is particularly if there's systemic symptoms or deteriorating renal function, because they may have a systemic disease that requires urgent diagnosis and treatment. Next. So when you do a referral, these are the sort of things I like to receive, because it really makes my life a lot easier. And it's great when I can tell a patient, I don't need to do any other tests because they've already been done. So obviously biochemistry and serial results of biochemistry is really helpful to me or to us. Hemoglobin, HbA1c, yes. I do quite a lot of myeloma screens in elderly people who've got unexplained renal impairment, and we do turn up people with myeloma probably a couple of times a year. So doing a paraprotein and serum light chains. Urine protein and albumin, of course. I've already made a case for saying urine microscopy and or urinalysis is actually really helpful to me when they come. And in general, some imaging is great. If they come in with a renal tract ultrasound, that's really helpful. Next. Okay. So I'm going to finish this part just with a few general tips as well. What I tell people with renal impairment, these are the two key things I tell them. Be careful to avoid dehydration. That's not the same as saying drink a lot of extra fluid. I mean, there's nothing magic about water, even though that is sort of the impression that's given out there. Coffee, tea, I get this question all the time from patients. Oh, but what about coffee? And I say, well, coffee is just flavored water. It's the volume of fluid that's important. But they don't need to drink excessive amounts. I tell people 1.5, 2 liters a day is plenty. Drinking 5 liters a day isn't going to make their kidneys any healthier. And if they are in a situation where they're getting dehydrated, warn them about stopping certain medications like antihypertensives, for example. And generally, we advise people to avoid non-steroidal anti-inflammatories, particularly long-term use. Short courses for gout, for example, okay, but I still feel a bit nervy about it, but definitely not long-term NSAIDs. Quite commonly, we're asked questions about edema, and edema per se is not really typical of renal impairment unless they've got nephrotic syndrome or very advanced chronic kidney disease. So early edema in an early situation, someone with relatively mild chronic kidney disease, isn't because of their kidneys in general. There's all the other causes, heart failure, etc. And probably the most common one I see is that people have got a bit of edema, and it's because they're on a big dose of amlodipine or a calcium channel blocker. And all that needs to be done is you just reduce the dose or change off the calcium channel blocker. I mentioned this to Raymond before. Certain medications need significant dose adjustments. The ones that I sort of my favourites in a way are antivirals like famciclovir, and pregabalin's the other one, particularly in people with advanced chronic kidney disease, both of them, like famciclovir or pregabalin, if not appropriately dose adjusted for people with advanced chronic kidney disease, like people who are on dialysis or near dialysis, they'll get profoundly encephalopathic, and I've seen it quite a few times. So just be very mindful of certain medications. And there's a whole bunch of other ones, but they're the two that I think of, and I'm very happy to answer questions about other medications. And in the end, don't be afraid to give us a call or contact us in the renal unit. We're always happy offer advice, and yeah, very happy to try and avert problems before they arise. So yeah, very please give us a call. And I think that was it. I had a few little sort of case vignettes I've just thrown together, but I thought maybe we'd stop there, and if people have got questions and stuff, please yell out.